So now it's 4 o'clock. We'll start. So good evening, everyone. On behalf of Neurological Society of India, we welcome you all for this joint webinar with Endoscopic Society of India. Myself, Dr. Kodishwaran, Chair of Webinar Committee, and Dr. Matthew Abraham, another Chair of Webinar Committee. Welcome you all for this 75th year celebration joint webinar with NESI. Today we have an interesting session of endoscopic complications. Dr. Prakash Nair is a professor of neurosurgery, Sri Chitra Institute of Medical Sciences, is the convener of this meeting. So welcome, Dr. Prakash. So we have two panelists today. Dr. Sumit Sinha is a treasurer of Neurological Society of India and secretary of NESI. Another panelist, Dr. Paritosh, is secretary general of NSI. So we have excellent speakers. We have 5 speakers from India and abroad. So I request Dr. Prakash to take over the session.
So a very good afternoon and a good evening to all of you. We have a session that is actually very close to my heart, which deals with the complications of endoscopic skull base surgery. We all talk about a variety of procedures and difficulty levels that can be achieved with surgical skill and experience. But management of complications stands alone because it defines a point of no return. It often can result in a lot of morbidity and can change the life of both the patient and the surgeon. This session is focused at presenting some of the devastating complications that can happen after endoscopic skull base surgery. And to discuss this, we have a panel of extremely experienced august neurosurgeons and ENT surgeons and radiologists. So we have Dr. Diego Mazzatenta from Bologna, who is a very experienced skull base surgeon, and for someone I know quite closely for many years. He has presented and worked in a variety of areas and has got a lot of interest in both skull base and neuro-oncology. He should be talking about management of IC injury. My colleague and friend, Professor Jayadevan, who is the professor and head of department of radiology and imaging sciences at Sri Chitra Tirunal Institute, who helps us with a lot of our cases. He will be speaking to us on the endovascular management of IC injury. Dr. Janvi is an associate professor of ENT at Amrita Institute of Medical Sciences, and she shall be talking about the variety of nasal complications that can be encountered after endoscopic skull base surgery. And Dr. Sushant, who's the additional professor of neurosurgery at PGH Chandigarh, shall be talking to us about the management of CSF leaks, which is an extremely devastating complication. At the end, we have Dr. Akhilesh, who shall be discussing various case scenarios. And we expect these cases to be interactive with the speakers and the panelists, providing us their feedback on how they will manage these difficult cases. To discuss all this, we have a group of very experienced panelists. Professor Sumit Sinha, who is the senior consultant at Max Delhi and also the secretary of the Neuroendoscopy Society of India. Dr. Sumit is the panelist for this program. And we have Dr. Paritosh Pandey, who is the secretary of NSI and who's also very experienced endovascular and neurosurgeon. So with this, I shall move forward and ask Diego to please share his slides and start his talk.
Good morning at all. Thank you so much, Dr. Prakash Nair, for your kind invitation, the whole organizing committee. This is my presentation. Okay.
Yes, sir.
Perfect. Okay. Good morning at all. This is my conflict of interest. I am scientific consultant of Integra. I came from Bologna, from University of Bologna, and I'm director of Center of Pituitary and Skull Base Surgery. I wish to thank my group because this pathology is possible to treat only in a multidisciplinary approach. So you can see there is an oncologist, neurosurgeon, ENT surgeon, radiotherapist, and also neuroradiologist, obviously. To avoid the vascular complication, it's most important to know the surgical anatomy, the pathology, get a proper surgical setting, and know very well and adopt an emergencies protocol because the problem of vascular damage is a possibility during the surgery. And in case of whole, an entire protocol are well known for the entire equipe. First approach. The approach, the endoscopic endonasal approach is very straightforward, elegant, and minimally invasive. But it depends on degree of pneumatization of the sphenoidal sinus. For the cellular type, to get the space of the supracellular or cellular transcribal approach is enough the wide anterior sphenoidotomy and maybe lateral displacement out of fracture of the middle turbinate. Conversely, when the pneumatization is not so well represented, in case of precellar or worst concal type, it's possible to perform a posterior septostomy, unilateral middle turbinectomy, and maybe unilateral posterior ethmoidectomy. In this case, precellar and concal type, it's more difficult to recognize all boundaries because it's well known by literature the damage of the internal carotid, the half part, it was observed during the approach, not during the tumor removal. Obviously, you will know all the anatomy of a sphenoidal sinus very well, know very well what is the um, midline of approach. This is the sella turcica, this is the optic nerve, this is optic carotid resist, paraclival carotid artery, and the V2 and Vidian nerve. But only, it's most important, it's really most important, knowledge the anatomy intradurally. A1, A2 complex, basilar artery, and also the vertebral artery. Because when you work a transclival approach, using the endoscopic approach, we work in front of the posterior fossa. In this case, it's very rare but possible the so-called kissing carotids. In this case, the pathology is very easy. It's a intracellular ACTH pituitary adenomas, but it's very difficult to achieve a radical removal and perform a safe procedure. This is the cellular phase. We open the bone, the periosteum cell, and with the microblock Doppler, it's most important to check both internal carotid because they are in the very close between, and they occupy the space intracellular. So it's most important with a delicate dissection working between a very narrow space between the two internal carotid arteries. It's most important to recognize before, during the neuroradiological workup. Also, the pathology is most important to recognize a different type of pathology. In this case, several surgeons affirmed it was a pituitary adenoma invading the inferior part of a cavernous sinus in the left side. But MRI was not enough. In fact, we performed an angio-CT scan and we allow a diagnosis of carotid, intracarotid aneurysm. It's most important to complete the neurological workup, avoiding dramatic complication. And also, like the knowledge of pathology is the most important because sometimes the error arrives because it's not so well performed all protocol of diagnosis. In this case, the patient with the lymphoproliferative disease, the patient complains of visual disturbance, pain, and epistaxis, referred by hematologist with suspected invasive mycosis. So this case was treated in another department, in NT department, and the MRI was requested, but the surgeon decided urgently to carry on in the operating room without review the MRI images. And this is what the problem. We had a nasal fossa, he displaced the middle turbinate, and in front of the ostium of sphenoidal sinus. We start to opening the osteosphenoidal sinus using a shiver. This is a suction tube. This is the ostium of a sphenoidal sinus. And after start the remodeling of using the shiver. As you know, the shiver is a cutting instrument. The surgeon perform a partial superior turbinectomy, allow a good space to enter the sphenoidal sinus, but finally, this was the result. A very important massive hemorrhage, arterial hemorrhage, started just in front of the ostium sphenoid. The surgeon skilled was able to compress and to stop the hemorrhages. So when you arrive to control the hemorrhages, the patient move on in an endovascular unit. If you see the MRI performed but don't observe by the surgeon, you can see clearly the aneurysm in the carotid artery in the left side. The lesson learned was overestimation of patient as immunopressed, underestimation of the history of epistasis, and inexperience of the radiologist's record. And also, the surgeon arrived only with CT scan, and this was the result. The patient was lucky because the follow-up showed non-ischemic neurological issues post-treatment. This is another case, ACTH pituitary adenoma recurrent. We are in the sella turcica. This is the tumor. This is the carotid artery in the right side, mammillary body. This is in the space, suprasellar space. Coagulate the part of the diaphragm cell. The surgeon start with a cutting instrument to cut the part of diaphragm cell. As you see, we start correct, but after we move on the left and cut partially the carotid artery and start the bleeding. As you can see, this is very, very narrow damage of internal carotid artery. In this case, it was possible with a very, very simple bipolar coagulation control the bleeding of tumor and achieve the gross total removal. You can see the mammillary body, and this was the result with a little remedy. It's most important to know that it's possible to operate in cavernous sinus in this case, like in this case, but it's very important to know the knowledge and the consistence of tumor. This is the pituitary gland. This is the internal carotid artery. And as you can see, the tumor is possible to remove using very close to carotid artery, suction tube, and curettes. You can see the double channel around the carotid artery safely. But it was important to recognize the consistence of tumor. And this was the results. Conversely, in case of the tumor was completely filled, we remove, in this case, the central part. This is the carotid artery, checked before by Doppler and neuronavigation. The surgeon try to remove a tumor with curettes, but the tumors change completely as a field, and we stop the procedure. You can manage the carotid artery in case of firm tumor. The topics of balloon test. The balloon test is not a safe procedure. The balloon test complication rate is about 1.5%. In our experience, bellaria pituitary adenomas overall, damage of internal carotid is 0.18%, and the bellaria series of the pituitary adenoma invading cavernous sinus is 0.24. In case of very correct selected indications, it's not mandatory to perform a balloon test. But sometimes for different tumors, for example, this is a very, very old case of December 1998 at the start of our experience. You can see very poor quality of analogical images. It was a recurrent chordoma of a lateral compartment of the left carotid artery. In this case, it was the problem of technology at that area. You can see this is the monopolar coagulation. Obviously, this was the result. It was not safe to use, but in this pioneeristic area, the technology was very, very simple. We control with endovascular procedure, and with months later, symptomatology reappears, and we perform a reduced surgery, allow a gross total removal, as you can see in this MRI. In case of a reduced surgery, take in mind always to perform the angiosity, such as in this case, here low drugs resistant, previous transfemoral surgery, persistence of high prolactin levels. We started with the angiosity, showed anything, we move to operating room, intraoperative massive bleeding, and the angiography showed a little pseudoaneurysm, probably before the previous surgery. Was the angiography, and the take-home message is that the CT angiography cannot exclude the presence of a small pseudoaneurysm. Take care in case of a reduced surgery. Another case, chordomas, biopsy in other department. We start with the tumor removal. The first part was soft tumor. This is the pituitary gland, this is the chordoma. Carotid artery is there, very, very lateral. The tumor is filled, but we try to remove. It was enough to mobilize only the tumor without direct manipulation of the internal carotid artery and start the hemorrhages. We control with packing. We close with endovascular treatment. We show the compensus, and we carry on in surgical, but it was not possible to remove due to the consistency of tumor. What's happened? What's happened is it was a two different tumor. The midline was very soft, a typical chordomas, vacuolized histopathological issue. In the right side, close to carotid artery, differentiated chordomas. Last case, 17 years old male chondrosarcoma, incidental finding with minor trauma, and this was a very large chondrosarcoma, and we decided to remove with the endoscopic endonasal approach. Under CT scan, it was completely negative, no aneurysm, no malformation, and so we started with the tumor removal. This is the video. With the video behind the sphenoidal sinus, we started to remove partially the tumor because we move in the lateral wall. We check with the neuronavigation, the microprobe Doppler. We know very well where is the carotid artery. The tumor is very soft, and it was enough to use only the suction tool without any cutting instrument or correct. We control obviously the hemorrhages. We start with the digital. We move in a neurological. We show a little damage of carotid artery. We move to control with angiography. Was the results. Left paraclavian internal carotid artery rupture. We perform obviously the compensation test, showed normal perfusion. And so we start in this case to put a stent. Step one, endovascular positioning of balloon, removal of nasal packing and the gases in the angiographic room under endoscopic vision in angiographic room, and placement of abdominal fat graft. Step three, covered PK papyrus stent placement, as you can see. And this was the post-ending of angiography, showing a correct perfusion. In this case, we choose to position in a stand, preserving the vascularization of the young patient. The MRI showed obviously a partial removal because we stopped in this part, remaining in this part, but at this time it was impossible to carry on the procedure because the patient is a dual antibiotic therapy for 6 months. So we showed also no ischemic or ARIAS in DVWI sequences, and the patient was discharged after 7 days postoperative. Lesson learned is to avoid this damage is most important to use the neuronavigation and microvascular Doppler ultrasound. The significant increases in use of neuronavigation, microvascular Doppler is the most important in a new era of endoscopic skull-base surgery. This is a OR setting, very complex, but it was mandatory to use all devices in this surgery because the endoscopic technique is combined with different surgery. This is a case of odontoid with atlas cervical fixation at the same times, exoscopic transorbital approach, exoscopic transcranial approach skull base, and combine micro and endoscopic. In other words, don't believe in neuronavigation always. The anatomy remains the most important tools to avoid this problem. In case of very clear the ACT protocol, compression, activate an interventional neuroradiologist, maintain cerebral perfusion, switch the free hands technique, temporarily reinforce with gaze or swab, and invite to the angiographyst. In this paper, we participated multidisciplinary. There are several aspects, several items to control. Patient risks, human error, process, technique, instruments, and environment could be very important to avoiding the intercarotid artery damage. As you can see, anatomical remain the most frequent factor report. Don't recognize where is the internal carotid artery. And don't forget the location is a paracellin, 61%, and the timing of injury, approach, and leisure retraction is almost 50% both. In conclusion, is no one is exempt from potential complication, but experience and teamwork allow to manage them effectively, minimizing their impact. Thank you for your attention.
Thank you, David, for the wonderful talk. We shall take questions at the end of the webinar after we've gone through the talks of the other speakers. Now I'd invite Professor Jayadevan, who shall be dealing with the endovascular aspects of managing both as vascular injury and vascular complications after endoscopic skull-base surgery. Jayadevan, sir, you can share your slides.
Okay. Can you see the slides?
Yes, sir, we can see your slides.
Okay, fine. Okay, good evening. So I think the previous speaker has already mentioned significant part of the carotid injury and its management, some part of the endovascular management also he has mentioned. So what I will do is kind of an, it's quite difficult in a particular case what method to be adopted. And most of the time it will be depends on the various factors related to the anatomy and procedure related factors. But in generally, I'll take an algorithmic pattern how to go about. So when we have an ICA injury, so what first as an endovascular intervention is what we do is whether we can do the patient, put the patient on antithrombotics. So if he is a good candidate for antithrombotics, we do a balloon occlusion test that I will come to that, whether can we do, can we go ahead. If he is good with the trapping angiographically, then we will go ahead with the trapping. That is a definitive treatment. But if the angiography is not favorable for the trapping or sacrifice of the artery, what we have to go with vessel preservation options like covered stenting with coil, flow diversion, just coiling alone. So this is a situation when we have a patient where we can give antiplatelet. But there are some situations where we cannot give antiplatelet, like ongoing hemorrhage. The hemorrhage is continuing, and we are planning for a re-exploration very early. Then hemodynamically unstable patients, severe coagulopathy, thrombocytopathy, and PNEA and all. In this situation, still we do a balloon occlusion test or angiographic assessment whether we can sacrifice the vessel. If that is favorable, we go with sacrificing the vessel. If it is failing, then we go with just preserving the vessel. We just do the coiling of the pseudoaneurysm. Otherwise, or the carotid cavernous fistula which has developed, or if that is also not possible, we'll have to go with the bypass. So we will go one by one then. Now, there are some situations where we will have some idea whether this will go in for carotid injury. That's usually the post-therapy, post-radiotherapy situations, revision surgery, bromocriptine, because prolonged, long-standing bromocriptine, the lesions are much more fibrotic and it is adherent to the carotid wall, and acromegaly because of the displacement of the vessel anatomy, and also because of the growth hormone itself is causing the endothelium and the vessel wall weakening. So these situations, it's better to go with a preoperative DSA and if possible a balloon occlusion test. And when we talk about a balloon occlusion test, We generally see the collateral pattern, like the primary collaterals and secondary collateral, vascular encasement, tumor vascularity, atherosclerotic disease, and secondary vascular abnormalities. So what generally the balloon occlusion test is 20 minutes normal pressure, 20 minutes under hypotension, that is 30% reduction of mean arterial pressure is for 20 minutes. But in emergency, this systematic way of doing balloon occlusion test is not always possible. And not always, but most of the time it is not possible at all. In an elective case, it might be possible. So when you do a sacrifice without balloon occlusion, the chance of a stroke is relatively high, even up to 30%. With balloon occlusion is fairly lower. So I'll show that this is actually a balloon occlusion test where the balloon is in the right ICA, and you can see that opposite ICA, so there is a good collateral and flow is from the right side. And here how we can see that the balloon occlusion test, see the left ICA is occluded with the balloon, and opposite from the opposite side the contrast is filling. So what we in emergency settings, what we do see is we just see the venous filling is synchronous or not, because generally in emergency setting the entire step of balloon occlusion test will be time taking and it will be complication prone also. That way, so the synchronous filling of the venous veins, we will see. If there is no delay, or if there is a maximum delay of 2 seconds or less, we will take it as a favorable cross circulation. Or the primary collateral like ACOM and PCOM is having size more than 1 millimeter, that is also a good indicator of a tolerance. So this is a posterior circulation. We occluded the ICA and injected through the vertebral artery and see the PCOM and the MCA is filling. This is a relatively better PCOM. And this is in another view where we can see the right ICA is occluded with the balloon, and we see the right MCA is filling through PCOM. So these are the better balloon occlusion, that collateral pathway scenario where we can trap the ICA favorably. This another important thing, we will see that we occlude the ICA. Here you can see the balloon, and we will see how the ophthalmic artery is filling. Now we can see that ophthalmic artery is filling retrogradely here, and at the end of that you can see there will be a crescentic shadow here, which is a crescentic shadow, which is actually choroidal blush, which indicates that the patient is getting ophthalmic, means the choroid and retina is getting filled through ECA collateral. So we can sacrifice ophthalmic segment of ICA also here. So in most of the scenario when ICA injury is there, the favorable and the definitive treatment is definitely the sacrifice of the artery. But when the collaterals are not good, we may have to preserve the artery. So the preservation of the artery depends upon the vascular anatomy, how is the ongoing bleeding is there or not, how severe is the injury, and is a pseudoaneurysm is there or not, and related antiplatelet risk. So with special preservation, these are the devices we generally use: covered stent, stent-assisted coiling, balloon-assisted coiling, flow diverter. Flow diverter, as in an emergent situation, when ongoing bleeding, generally we don't prefer unless we secure the bleeding pseudoaneurysm. Otherwise, flow diverter we don't prefer. So generally the first line is a covered stent, stent-assisted or balloon-assisted coiling. So these are the first is covered stent. It is a quite stiff device. Or if it is not possible, then we consider balloon-assisted coiling. That is also not possible when it is neck of the pseudoaneurysm is very wide. We try to go with the balloon-assisted coiling. Then sometimes a flow diverter. So flow diverter alone we will not use. We will have to put the coil in the pseudoaneurysm. So most of the scenario, the patients are not on antiplatelet because they are coming immediately after the surgery from the surgery chamber, or immediately after, say, 1 or 2 days after surgery. So after placement of any of this device, we may have to give a intravenous and then intra-arterial this GP2 B3A inhibitors, so that is IV antiplatelets. So this is a very highly aggressive antiplatelet therapy. Sometimes already formed thrombus also can lie. So we have to be little careful in using these drugs. Now, when you use a covered stent, even though it is, if it is a vessel is straighter, covered stent is easiest method. But when the artery is very tortuous like this, you cannot take this in the tortuous ICA. You cannot take this stiffer covered stent into the desired location. So in this situation, you cannot you use a covered stent. Like when the second and third and fourth image, the cavernous segment is a very tortuous. The anterior genu and posterior genu, there is a significant tortuosity you can see where you cannot navigate your stiffer covered stent. So in this situation, when the anatomy is very tortuous, covered stent is not an option. There's one case where covered stent has been placed in a pseudoaneurysm, but you can see that the covered stent got kinked. So this is one complication and problem with the covered stent. Because it is a stiffer device. These covered stents are mainly meant for coronary, not for intracranial. So dedicated intracranial covered stents are usually not available. So we have to be very careful in picking the covered stent treatment for a particular lesion. Now, this is a case where after post transsphenoid surgery, there is a large pseudoaneurysm projecting into the sphenoid sinus. Associated, there is a carotid cavernous, direct carotid cavernous fistula. You can see the vessel, this cavernous sinus and the cortical veins are filling on the opposite side also. So when you see the angiogram, there is a large pseudoaneurysm and there is a carotid cavernous fistula which is filling into the superior ophthalmic vein. And you can see that it is filling into the sphenoid sinus in the AP view. So the collateral flow is relatively good. You can see the across the ACOM it is filling. So this patient underwent sacrifice of the parent artery, and after parent artery, you can see the complete cross circulation across. So this was done after checking the collateral. So this patient didn't go for a complete balloon occlusion. We just see the synchronous filling of the cortical veins after balloon occlusion. This ICA trapping, and you can see that up to the ophthalmic artery, ophthalmic segment of the ICA, it is filling retrogradely. This and another artery is an aggressive tumor in the petrous area. After surgery, you can see there is a pseudoaneurysm. The patient presented with immediately with the autophagia, where when you see that the collateral circulation is not good, it is not supplying the opposite side. The indented, the left side, it is the ACA is not supplying, so you cannot safely sacrifice it. But through the MCA, through the PCOM, the MCA and some ACAs are filling. But since only one collateral is there, we didn't go first with trapping. We first tried stopped the bleeding with a balloon assisted coil with putting a balloon, and we coiled it. And at that time it has stopped the bleeding, everything has stopped. The patient again came with a small amount of bleeding with the compaction of the coil and with the enlargement of the pseudoaneurysm. So now it has come to a situation that we may have to sacrifice the vessel. And if this large, this one covered stent, we cannot use it because the ICA is quite large. So we have trapped the ICA, and after trapping, the first, second day image shows there is no infarct. Fourth day, there is small patchy infarct started coming. And on 8th day, patient developed a significant patchy infarct. So this is the reason why when we trap the aneurysm, when you don't have a good collateral flow. But in this situation, we had to trap it because there was local inflammation. So which is infection also, which is preventing for a ICA, ECA bypass, and also the vessel preservation options are also not possible. This is another case of a transsphenoidal pituitary surgery. After that, the patient on table developed a larger pseudoaneurysm, and immediately the patient shifted to the cath lab, and it was they have done this covered stent. This was done in some other hospital, and it has kinked actually, and which is actually caused a flow diversion because it didn't actually occlude the pseudoaneurysm, which has caused the endoleak, and the patient again continued to bleed. When the patient reached here in our hospital, the aneurysm was still filling. So here, what we have done is here also the collateral circulation is not good. On the right side, this is a stent we can see here, but the right ICA is not filling from the left side, and also from the PCOM also the MCA is filling, but it is faintly filling. So we didn't go for a sacrifice initially. So what we have done is through the between the vessel wall and the already placed um, covered stent, we place some coil inside into the pseudoaneurysm to arrest the flow, arrest the bleeding, and then we kept it like that. And after a few days, again, patient with a small amount of epistaxis, and at that time we had to sacrifice the artery. So we sacrificed it completely by putting coil into the sac and also into the parent artery. So now, by that time, the patient has developed a significant collateralization because the stent was actually causing a flow limitation antegrately, which has developed further good flow from ACOM and PCOM, and patient didn't develop any problem. So this is after the trapping of the ICA. So this is pituitary, it's not a pituitary lesion, it's a craniopharyngioma lesion. The patient, a 21-year-old male patient. After surgery, first same day or post-operatively, very clean surgery, no bleed, nothing, only some surgery-related pneumocephalus, some packing evidence. Otherwise, nothing is there. Patient was doing well, extubated, but on the 8th day, patient developed a right hemiparesis and aphasia, and the imaging showed a left thalamic infarct, and MRI angiogram shows a significant severe irregular narrowing of the ACA, MCA, and ICA. So angio showed, you can see that very severe, smooth, and some areas irregular narrowing of the ICA, bilateral ICAs, MCAs, and ACA. So here what we managed is initially we tried to open with giving intra-arterial milrinone. It opened partially, but not completely. But the other AC is also not going into open. But the IC is still remaining significantly spastic. So if you leave it like this, it will again go in for complete occlusion. So what we have done is a balloon angioplasty, same stage itself, and it has completely opened up. So sequentially angioplasty from MCA to ICA, right and left side, and it has opened. So this patient over a period of had a good recovery. This is a lateral view. And this another patient, similar patient, pituitary lesion post surgery after 4th day, developed a severe vasospasm, and this is actually managed with the milrinone, and after that there was not much of recurrence of vasospasm. So this is another patient which is a pituitary macroadenoma surgery. During surgery, surgeon has identified a significant hemorrhage from the left side, and the patient was that area has been packed and shifted to the cath lab. We did angiogram, but the angiogram didn't show any aneurysm. So this what is showing the projection in the right eye is actually it was a PCOM infundibulum, and the left side also there was no definite aneurysm. Actually, the surgeon was suspecting the injury was probably on the left side. So we have done 3D angio, everything, nothing we couldn't find. And this is AP view. There was no lesion, no definite aneurysm. But on the 5th day, the patient was doing well. There was no breakthrough bleeding. But on the 5th day, CT angiogram showed there is an ophthalmic segment, small pseudoaneurysm. Actually, since the patient was relatively well, so they have surgically managed the aneurysm. So in short, so we usually endovascularly manage the ICA pseudoaneurysms or ICA injury. Primarily, we look in for whether we can sacrifice it or not, because that is a definitive treatment. But for that, we have to have a good collateral circulation. Most of the time, the synchronous venous filling, a delay of less than 2 seconds will give a good idea regarding whether the patient will tolerate. If the patient is not tolerating, or if the occlusion test, the synchronous venous filling is not there, then we will preserve it. Preserving either with a covered stent or a stenting with the coiling, or flow diverter with the coiling. Sometimes coiling alone to secure the pseudoaneurysm to avoid further bleed. If nothing is working, then it has to go for a ECMC bypass. So regarding the device selection, covered stent, if you take, we generally take it is rather easy to deploy if the vessels are straight enough to place it. Otherwise, if it is a very tortuous anatomy, generally we don't prefer. And then options are stent and flow diversion. So stent and flow diversion. Stent is usually mainly used for a wide neck, a very large pseudoaneurysm. Flow diversion also wide neck pseudoaneurysm when the anatomy is very tortuous. When we use a stent and a flow diversion, definitely we have to coil the rent tightly to avoid a further leak. And just if the pseudoaneurysm mouth or the neck is very small, sometimes we can coil the pseudoaneurysm with the coil alone. Their antiplatelets is not required. So this is a usual workflow we generally follow. But in some situation, a combination of all this we have to do sequentially. Thank you.
Very extensive talk. Actually, you covered another very important area, which is vasospasm, which we see sometimes after skull-base surgery. I think it is under-recognized, and the results of management, endovascular management, are extremely gratifying because these patients tend to recover their deficits and they become well very fast. So thank you so much, sir. We shall take questions at the end of the session. And now I'd invite Dr. Janvi to present her talk on the nasal complications following endoscopic skull-base surgery. Dr. Janvi, you can share your slides.
Yes, thank you very much, sir. Can you see my screen?
Yes, we can see your screen. Can you share? I can see your slides.
Yes, sir. Just a moment. A very good evening to everyone. I would like to thank the Neurological Society of India and the NESI group for inviting me for this talk today. The task bestowed upon me today is to specifically speak about the complications in the nose, the local complications that we maximally come across. And let's begin. So just a short introduction. During the 1980s, when open craniofacial surgery and skull-base reconstruction with the gallia and fixation with metal plates and bone flaps was in place, prolonged ICU stay, a higher risk of post-op infections and complications, also with the lumbar drainage maximal usage was seen. 20 years later, the patient has now come up to the option of minimally invasive endoscopic surgery, maximal tumor resection through a natural orifice, with the advent of the powered instruments, the different angled endoscopes, as well as the nasoseptal flap. Morbidity and mortality we have seen has decreased dramatically. And yet, each approach has its pros and cons. Let's speak about two case scenarios. A 43-year-old male, known hypothyroid and dyslipidemic, underwent extended endoscopic endonasal surgery for a pituitary macroadenoma. On the post-op day 4, he developed 3 episodes of minimal epistaxis, which were controlled conservatively in the outpatient department itself, although we did not think of probably whether these were sentinel bleeds. On post-op day 6, he came with massive epistaxis. The DNE, when I put my 0-degree endoscope, I saw an active spurting vessel from the anterior wall of the left sphenoid coming all the way to the vestibule. He was packed immediately, but while awaiting his CT angio, he had a massive epistaxis once again, went into a transient cardiorespiratory arrest. He was immediately repacked, intubated, resuscitated, and shifted to the operation theater. In the theater, there was no active bleeding point found once the patient was taken under GA, while his DSA done immediately showed a pseudoaneurysm with contrast extravasation from the sphenopalatine artery on the left side. And angioembolization was therefore done by the neurovascular intervention team, after which the patient has been asymptomatic. This was the pre-angioembolization arterial blush visualized and the post-embolization pictures. Coming to the second scenario, this was a referred case of a 54-year-old lady who developed bifrontal headache of insidious onset duration, not relieving with medications. She was known to have a giant pituitary macroadenoma, for which she underwent excision, transnasal transsphenoid with EBD placement. Following which she developed weakness of the right lower limb, aphasia, and the CT brain showed ventriculomegaly, and septostomy with left VP shunt was done. She was referred to us with diabetes insipidus and dyselectrolemia, and also an active CSF leak. This was her preoperative endoscopy. She had developed sinusitis with probably a flap necrosis and significant crusting of the nasal cavity because she was unable to clean by herself. She came to us with low GCS. The MRI showed query fungal abscess. We had to take her into OT because of the active CSF leak. Now, what you're looking at here is an absolute flap necrosis, and not only the pedicle flap, but also the fascia lata that was placed had actually got necrosed. What is the reason for flap failure here? Is it pedicle injury? Was it a narrow pedicle when the flap was elevated? Was it the fungal infection and sepsis? Was it poor post-op cleaning? All of these can be debated. So, coming to the complications of endoscopic endonasal extended surgery, they can be divided into early, intermediate, late, major or minor, nasal, intracranial and systemic, or functional and non-functional. Coming to the early, immediate postoperative complaints which we might come across in the ICU. CSF leak, regarding which Sushant sir is going to speak about in detail following this talk, so I will not go into that. Cerebral infarct, regarding which we have spoken, which is probably due to vasospasm, which sometimes goes unthought or unnoticed. Orbital complications, which also are things that you think of immediately in the ICU when you see the patient. Vascular injuries and electrolyte abnormalities. Now, what are the things in the nose that we don't commonly tend to think of? Nasal pack related, CO2 retention, which in turn causes cardiopulmonary stress and can even cause ECG changes. Nasal block, which the patient experiences with significant mouth breathing, complaining of throat dryness. Breathing difficulty, if the patient already has a pre-existing OSA, but you cannot give him a BiPAP or a CPAP. In fact, there are proven papers which talk about the influence of bilateral nasal packing on sleep oxygen saturation after GA and comparing the ABG analysis in post septoplasty patients. Similarly, will apply to endoscopic sphenoid surgery also with conventional packs versus packs with airway, which actually show significant difference in oxygen saturation levels in patients who have tight packs in the nose on both sides. At pack removal, what complications can we come across? Flap necrosis or flap failure. Bleeding at pack removal, which could sometimes be profuse, like we already saw in Jaydevan sir's talk. CSF leak. Yes, CSF leak that can be either with the pack also inside, the patient may complain of a leak, or at pack removal, once the pressure is released, we might see CSF leak. Purulent discharge in the sinuses. Beware, if we keep the pack too long, the patient can actually go into a toxic shock syndrome, especially if the antibiotics are stopped too early, also causing mucositis and more crusting. Next, coming to the intermediate complications, which are seen at the first few follow-ups in the OPD. Those are most commonly sinecate, then patient could develop a chronic rhinosinusitis or an infected surgical cavity, crusting due to poor nasal cleaning, palatal necrosis, and orbital complications like exposure keratopathy. Coming to a patient in whom there was significantly gross DNS intraoperatively, and although the patient was corrected, the cartilaginous anterior part was corrected intraoperatively itself, the patient found it difficult to do nasal cleaning on the right side where there was gross DNS, and the Hadad was taken on the left. So a reverse flap was taken, and actually from the right side, the mucosa was inverted with a reverse flap and quilting sutured, and a splint was placed on the right side in order to, the video initially is not playing, sorry. This is the video I wanted to show you where there was a gross DNS which was detected preoperatively. A reverse flap was taken with a quilting suture and a splint was placed on the right so that the patient would not have a sinecate post-op. And yet, in spite of the splint and meticulous cleaning that the patient was advised, the patient developed a significant sinecate which exactly blocked the internal nasal valve area, impairing the patient's breathing while she was already a case of acromegaly and she had significant OSA. So we literally had to put her on a tracheostomy because of not being able to give her the CPAP and the sinecate. Next, crusting. Now, the posterior part of the nasal cavity looks very wide. It looks very spacious. It looks like everything is good. There's crusting only at the surgical site. But anteriorly at the internal nasal valve area where the air is actually entering into the nasal cavity, and that is where the entire breathing cycle is controlled. That is where this patient had significant crusting, similarly due to poor cleaning. You will see this now. So this patient actually had crusts blocking the entire internal nasal valve area, which literally had to be excised in the OPD itself and cleaned. This is a patient who developed palatal necrosis following an extended nasoseptal flap, where the nasoseptal flap was the varied nasoseptal flap with the nasal floor significantly extending all the way up to the inferior meatus was elevated. And I thank Kiruba sir for these pictures. This patient on the second day post-op actually developed a bleb on the hard palate, and few days later, the patient was found to have palatal necrosis with osteomyelitis of the palate, and which was later again corrected with this thing mucosal flap, but this patient had actinomycosis and she had to go on antibiotics for 2 months. Next is a patient who developed chronic rhinosinusitis because of poor nasal cleaning and came with purulent discharge with headache and nasal block. Now coming to the late complications that you may come across, which are seen usually few months postoperatively. For example, external nasal deformity, mucocele, which happens due to impaired drainage pathway. It can lead to proptosis, diplopia, headache, significantly affecting the patient's daily life, ophthalmoplegia, and blindness. Now, does external nasal deformity actually affect the patient's daily life? Yes, probably depending on the part of the country that we are in. So if we look at the patients in South India, they're very fond of wearing nose rings, and they're very fond of course, everybody is fond of their external appearance. So external nasal deformity also must be significantly kept in mind. Then atrophic rhinitis in cases with extensive mucosal resection, extensive turbinate resection, where bilateral Hadad flaps have been taken for patients, bilateral middle turbinates have been removed. These patients suffer significantly with atrophic rhinitis. Although when we are looking into the nasal cavity with an endoscope, it's a very roomy nasal cavity, but the patient constantly has a feeling of a blocked nose and significantly foul smell crusts that keep coming into the oral cavity as well as out through the nasal cavity. These patients are usually treated with 25% glucose in glycerin drops. Then altered sleep cycle is something that is under research, but above all, we will come to olfactory disturbances. So coming to what we spoke about, external nasal deformity, which is seen about 6 months post endoscopic, extended endoscopic endonasal approach in this patient. Similarly for a pituitary macroadenoma, which was then corrected with a rhinoplasty using rib cartilage. Second, coming to a mucocele, this patient came to us with a bilateral frontal mucocele 15 years post this thing. He underwent a bilateral frontal craniotomy, bifrontal craniotomy, as well as endoscopic correction and anterior skull base reconstruction following a road traffic accident where he had multiple anterior skull base fractures. This actually, in fact, the frontal mucosa was supposed to have been cranialized and bone wax was placed at the frontal recess. So in order to completely demucosalize the frontal recess and the frontal sinus after the mucocele was drained, it took 6 hours to literally communicate it endonasally again. Coming to another very important function that sometimes we might not give enough importance to, that is the olfaction, which significantly affects quality of life. Parosmia and dysgeusia debilitate daily life literally and should never be considered as an undervalued sense. There's a very nice paper by Professor Stamberger on quality of life analysis, where 69 and 61% of skull base surgery patients actually complain of smell disturbance and crusting respectively post extensive endonasal surgery. Thus, preservation of olfaction can significantly improve the quality of life of the patient postoperatively. Tips and tricks in order to preserve olfaction are mainly two. One is making sure that the superior incision of our nasoseptal flap lies at the level of the sphenoid ostium up to the anterior end of the middle turbinate. And second, the elevation of the olfactory mucosa and removal of only bone along the anterior wall of the sphenoid and in transplanar approaches as far as possible. I would like to show something that we have been doing recently in patients with obstructive sleep apnea if they are not already used to CPAP daily. This is a patient who had significant OSA but was not used to using a CPAP preoperatively, and hence we avoided a tracheostomy in her during her pituitary adenoma surgery, and postoperatively we placed nasopharyngeal airways on both sides in the nasal cavity, and above that, following on the flap, the merosul packs were placed, thus keeping the airway patent as well as the patient comfortable until pack removal. This is showing a video through the nasopharyngeal airway, which was anteriorly then secured with quilting sutures on the anterior end of the nasal septum and outside too. The assessment of impact on endoscopic endonasal extended surgery patients can be done using the SNOT-22 or the Sinonasal Outcome Test Questionnaire, which is a very useful tool to actually assess how much the patient has got impacted in their daily life due to this surgery. Each symptom is being rated from 0 to 5 and a total score ranging from 0 to 110. What is our take-home message today? Skull-base surgery, like already mentioned by all the previous speakers, is a multidisciplinary care work and a teamwork in order to give the patient better quality of life. A preoperative team discussion to plan the best suitable approach would always be our savior. And respect nasal mucosa wherever possible, unless it is interfering with surgical exposure and resection of the tumor. A strict postoperative follow-up, including nasal cleaning, and learning to manage complications rather than fearing them will always help to improve the patient's quality of life. The main point to convey here is that sometimes these are things that we might not consider important enough to pay attention to, the crusting that the patient faces, the olfactory disturbances, but these are things that actually impact the daily quality of life of the patient and can significantly affect their mental health too. So we must remember to give equal importance to these symptoms too. I would like to acknowledge my mentors and Dr. Kiriba for sharing his clinical pictures. Thank you very much, and I hope we can all meet again at Endo Goa in 2028 to discuss further about the same. Thank you.
Thank you, Janveer. I think you have really touched upon one of the most important aspects of skull-base, endonasal skull-base surgery, and that is the management of the nose. And patients do really have nasal complaints unless they're taken care of by adequate ENT cleaning. We'll take more questions on this as we finish Dr. Sushant's talk. So with this, I invite Dr. Sushant to talk to us about management of CSF leaks.
Thank you, Dr. Prakash. And first of all, I would like to thank the Neuroendoscopy Society of India and the Neurological Society of India for this opportunity. So I was given the task to cover the management of CSF leak following endoscopic skull-base surgery. Although we discussed several times the management of CSF leaks, but in total, if you consider how we manage the CSF leak in our daily practice, it is the post-operative CSF leak, either whether to observe them or to put a lumbar drain or to straightforward go for a repair. And another most important point is to prevent the CSF leak. So we have to take all intraoperative measures to do a proper repair so that will prevent the post-operative CSF leak. But still in the post-operative practice, lumbar drain is still there, but there are lots of debate on this. So this is one of the beautiful paper that came in 2018, a randomized trial from Pittsburgh, where they concluded that perioperative lumbar drain in high-risk endoscopic endonasal skull-base defect found that they were associated with significant reduction in the post-operative CSF leak. So in continuation of this paper, so there are several works still going on, and I'll just brief about the few points. So as it is a randomized trial, they randomized 2 points. That is, the intraoperatively they found out the high risk, the high flow. They categorize them at if the dural defect is more than 1 centimeter square, extensive arachnoid dissection is there, and the dissection into the ventricle of the cisterns. So these are the criteria. Based on them, the half of these patients will put lumbar drain under general anesthesia after closure, the repair of the flow. And the lumbar drain was kept for almost 3 days, and 10 ml per hour were drained. And without doing a clamp trial, the lumbar drain was taken out. And they concluded that without lumbar drain in these high-risk cases, the CSF leak in the post-operative period was almost 21.2%, and with the use of lumbar drain, it has dropped down to almost 8%. And in the subgroup analysis, they found that these are not the sellar and suprasellar regions. Rather, these are the anterior and the posterior cranial fossa lesions where the lumbar drain worked significantly in reducing the post-operative CSF leak. Probably it is the vascularis pedicle flap that was not long enough and wide enough to cover the anterior and posterior cranial fossa, where the lumbar drain was used as a good protective factor to prevent the post-operative CSF leak in these cases. After that, this is should we go for a lumbar drain in all these cases, and should practice? When I searched on this this topic, so I found few papers And this is another beautiful paper where there is a randomization of the lumbar drain versus no lumbar drain. So intraoperatively using lumbar drain, they found, and this group from China, they found that there is no significant difference in the postoperative CSF leak incidence between these two group, lumbar drain versus no lumbar drain. And rather they found that patients where the lumbar drain was inserted, they have a longer hospital stay. And they concluded that routine placement of lumbar drain should not be a routine practice, and it should be customized for the extended anterior skull base surgeries, and it should be customized from patient to patient, should not be a routine practice. So this is another paper, another review actually. This is a very beautiful article. And when we analyze this, we found that there are several articles, they concluded that yes, lumbar drain is effective. But when individual factors were analyzed, and they concluded that these are the high flow leaks intraoperatively, those are the cases where intraoperative lumbar drain placement was really helpful in reducing the postoperative CSF leak, not of the tumor type or the repair variety and the mixed or the pituitary adenoma. So using lumbar drain or not using lumbar drain intraoperatively, still it is a debate, but particularly for those cases where there is the risk for the high risk for the CSF leak, the lumbar drain can be considered intraoperatively. For postoperative CSF leak, so lumbar drain may or may not be used, but the one of the oldest article that was published by Kassam et al. In 2011, they, when analyzed their 800 cases of anterior skull base procedure, they found that the postoperative leak was almost 15.9%. And majority of these patients improved with the use of lumbar drain. And during this lumbar drain, they decided if it is not improving, then they consider redo surgery and repair of the skull base. And only in few instances, they have also open cranial surgery in these cases. So another group also suggested that the lumbar drain in post-operative period, that also should not be a routine in all the kind of CSF leak. Rather, in cases of the low post-operative like CSF leak, they found that the cure rate of the CSF leak was 94.4% in the continuous lumbar drainage group versus 93.3% in the control group. That means in case of the low flow leak, lumbar drain is equivocal. So these kind of patients may be observed without putting a lumbar drain. And there was only with the use of lumbar drain, rather there was few cases of meningitis was also there. And it is, although it was not significant, but it was a matter of concern when it is compared with the control group. So the debate about the lumbar drain is, we can conclude that yes, it is useful for the high flow leaks, but if it is coming to the low flow leaks, then those patients may be observed without a lumbar drain. And the duration, in some centers, it is only 3 days, some centers it is 5 days. And during lumbar drain, then doing a clamp test to look for whether the CSF leak is happening or if the leak is not happening, that is also another debate. Some consider that with lumbar drain, if you do clamping after 3 days or after 5 days, if there is CSF leak, then that is the indication for going for a redo surgery and repair of the skull base. So this is not a uniform practice and result or across major centers. So this should be customized from patient to patient, and with our practice, we can practice lumbar drain from, although it is very heterogeneous. So prevention of CSF leak is another point. So if you do a good intraoperative repair of the skull base following extensive endonasal endoscopy surgery, so that could be the best way to prevent post-operative CSF leak. So there are various techniques have been described, like the fat packing of the sella. That was the first thing that we do after doing a endoscopic skull base surgery, after taking out the tumor, to fill up that gap so that the intracranial CSF pressure will not get transmitted through the nose and will dislodge all our graft. And most of us, we use a facilita graft. And since the Haddad's paper, the nasoseptal flap is in routine practice, some of us use artificial glue, some may without artificial glue. And synthetic dural substitutes are there, although they are not in routine. Multi-layer techniques it is concluded that multi-layer techniques should be and must be considered in case of extended skull base approaches. And finally, is the dural suturing, which personally I do practice and of course I promote a lot to prevent CSF leak in these kind of cases. Coming to the gasket closure technique, so this is the article that published highlighting how it is being done. That everybody know that after the taking out the tumor, so the facilita graft has to be 1 centimeter larger than the defect, and it's an overlay graft, and over this we use a autologous bone graft or artificial buttress, and it has to be put inside just like a gasket, so that if the CSF, the intracranial pressure will like increase, so it will just push and it will prevent the graft to dislodge, and finally this will prevent the postoperative CSF leak. But in case of extended endoscopic skull surgery, this like gasket seal technique may not be very helpful, and it is practically not possible. And it was in 2006 that for the first time the nasoseptal flap was published. And in their series of 44 cases, Haddad et al., they described that they found the postoperative CSF leak was dropped down significantly, which was like described as 20% to 40% in the previous paper. It was dropped down to almost 4.5%. And later on, there were several series who included nasoseptal flap into their practice to repair the skull base defect. And they found that the rate of the postoperative CSF leak dropped down significantly. And when using nasoseptal flap, so it is a matter of concern that in case of nasoseptal flap, it is not only the nasoseptal flap. Rather, we should like consider like packing the cavity and then using the free flap, then over that nasoseptal flap and using a glue. So it is not the nasoseptal flap alone. And in several series also, they consider plus or minus lumbar drain. But overall, they found that it is the nasoseptal flap that is the key point in preventing postoperative CSF leak. I'll not go into the details of it. Everybody of us know that it is based on the septal branch of the sphenopalatine artery. And the length and the breadth of this nasoseptal flap is usually considered depending on the location and the size of the tumor and how much is the tumor, the extent is there. So depending on that, it can be like customized from patient to patient. And if it is needed, then the inferior, close to the inferior turbinate also, that the floor can also be utilized if the broader flap is required. In addition to this nasoseptal flap, this is another technique was published by Kasam et al. In 2008, that in case of high risk cases, what they do is they put an inlay graft first. This is a free facilita graft, and the facilita graft size has to be larger than the defect. So they consider that if you put a larger graft inside and over that put another free flap, free graft of the facilita, then over that use the nasoseptal flap and glue. So they claim that with this technique, if there will increase in the intracranial pressure, so the CSF pressure when increases, that will push the facilita graft, the inlay facilita graft, that will push and that will come in close contact with the dura, and that will prevent further the CSF leak. And in that paper, they found that the CSF leak rate has dropped down to almost 1% with this technique. So there are various techniques are being practiced in current scenario with the use of nasoseptal flap, and found that the postoperative CSF leak has dropped down. Another important concept is using a dural suture. I'll slightly go into the details of it because this is whatever you talk about, like the gasket seal technique, vascularized pedicle flap, using a bone cartilage to support and use of glue. So the main aim is to hold all this graft in place, because there is a large defect is there. If the graft is in place for almost 3 to 4 days, then that will give some time for the free flap or the pedicle flap to get like adherent to the floor. And once it is adherent to the floor, then the chances of CSF leak will gradually reduces in the post-operative period. So those who are interested can go through this video. I'll just show a small video showing the steps. Several times I have also described this, how we use this. So in most of the cases, we try to preserve the dura, or we cut the dura in the U and V shape. And after doing a packing, what we do, we take a simple suture and we prepare a knot outside and gradually push it inside. So this is slightly different from Professor Goto's group in Japan, what they used the Osaka knot technique. They prepare a knot and they just slide it. So while sliding, there is a high chance that as the dura is very thinned out because of the tumor, that may give way. So instead of like pulling it, we push the knot inside, and we believe that this will help us in putting a like securing a knot without having damaging the already compromised dura. So if you do this, then this will allow us to like, or this will help to give some additional strength, and the entire the graft will be in place, and this will give additional support. At times, why this is very important, because if you consider few other cases also, when you consider the complete excision of tumor, like this was a case of the functional pituitary acromegaly, we consider the taking out the entire tumor. And what happened after taking out the entire tumor? So this is the scenario. So this is the arachnoid is completely bulging. And once the arachnoid is completely bulging from all around the cavity, we consider the entire tumor has been taken out and there is no residual tumor. But in this kind of scenario, you look at this. So this is a pulsatile arachnoid. So in these cases, if you do packing intraoperatively, there is very high chance the fat may get dislodged. And whatever graft we place here, so if you do a routine practice of how we do a closure, there is a high chance that if it will keep on bulging, then on day 3 or day 7 or after discharge, the patient may have a delayed CSF leak in these kind of cases. So to avoid this, what we do is, in addition to our packing, we put 2 or 3 sutures, and we also suture the facilita along with the dural edges so that everything will be in place, and that will prevent the immediate as well as the delayed post-operative CSF leak, and that will mitigate all these like the pulsatile arachnoid in this case. So if the arachnoid is not intact, like in case of tuberculum cell meningioma, we have to dissect the arachnoid, because in the first paper, from the first slide as I've shown, the dissection of the arachnoid and opening of the arachnoid into the cysternal space, it is a high risk factor for the post-operative CSF leak. So the scenario will be something like this. Once we take out the entire tumor in these kind of cases, so everything is open. So in this case, if you pack the fat, then with each pulsation, there is a tendency to come out. So we can also argue that putting a vascularized pedicle flap also makes some sense, that it will completely close. But if you put 1 or 2 sutures, here we do not repair the dura, rather we put a like holding suture from the tuberculum cell area to the clival dura. So the dural edges, if you put just 2 or 3 sutures in these kind of cases, that will hold the all graft in place. And over that, we can use our free graft. Then over that, we can use our vascularized pedicle graft. So this will help in preventing the delayed CSF leak in these kind of cases. Another important point, the point was the communication with the ventricle or communication with the cysternal space. Like in this case, after excision of the tumor, as the tumor was extending into the third ventricle, so the entire skull base is getting communicated with the ventricle. So in these kind of cases, the same fundamental is that after putting the fat graft, we put 2 or 3 sutures so that it will be in place. So the fundamental is, if you put like 2 or 3 spaces, like in the second case also, we do extra arachnoid resection to take out the entire tumor. Once you do extra arachnoid resection, everything is opened up. So the intraoperative, like securing the CSF leak and intraoperative completely like mitigation of the CSF leak is very, very important in these kind of cases. So what we do is, in the same technique, that we, in addition to this kind of the packing of the cella, we also put 2 or 3 sutures in this case so that it will hold in place. And after that, in addition, we put the free graft or the pedicle facilita. This is another scenario. This is very important in this kind of case. This is simple arachnoid cyst, and we have discussed in several times, and we have received patients from other centers operated endoscopically and have delayed CSF leak. The cause of CSF leak in this kind of scenario is this one. In these kind of cases, once the surgery is done, it is very simple. Once we put some fat, this will go inside because the cavity is very large. So as the cavity is very large, it is too difficult to pack the entire cavity with fat, because this will dislodge into the cysternal space here and there. So what we do, because if you do not pack it properly, then the chances of post-operative CSF leak is almost more than 90% in this kind of cases. So what we do is, in addition to closure, we also suture the fat graft along with this. So the fat is sutured to the dural edges, both the anterior and the posterior. And the proper suturing of the fat is very important. There is a small defect here, and you just see intraoperatively, after this, we wait for almost 5 to 10 minutes. And because there is a small gap is there, and through that gap, again, the fat is coming out. That means post-operatively, the chances of like the post-operative CSF leak and dislodgement of fat is very high. So we take care of all these like small the openings, and we suture the fat graft in all around. Then we do the standard repair, and this will help in preventing intraoperative CSF leak, and ensure that in these kind of cases, post-operative CSF leak chances are very less. These are few another cases which require that opening of the diaphragm cella. Here in this case, we opened up the diaphragm cella, but we didn't cut it. Few series have described that cutting of the diaphragm cella, and they suture the diaphragm cella in the midline. But we open up the diaphragm cella from the anterior tuberculum cella dura, and once it is like opened up and the tumor is completely taken out, we try to suture the diaphragm cella into its like the original place. although the complete closure is not practically possible in this kind of scenario, but we can convert the large defect into a small ones. And once the defect is converted into a small one, then the fat packing of that defect is relatively easy in these kind of cases. And in addition to this, we use the facilitator graft and the nasoseptal flap, and that will take care of the postoperative CSFT. So another important area is post redo surgery and post radiation. This is an example where the patient was diagnosed with the histopathology shown giant cell tumor, and patient had a recurrence. Patient underwent the second time surgery, and patient underwent the cranial radiation. And following radiation, there is a recurrence, and this time initially the tumor was extradural, and finally the tumor regrown into the intradural cavity. So we plan to open up the dura in the middle. Here, after taking out this, so the entire tumor is intradural, and the clivus is completely like already eroded. So we open up the dura in the middle, and we didn't coagulate the dura. We try to just dissect the tumor from the dura and try to keep the dura. So once the entire tumor has taken out, so the scene is like this. So this is only the dural edges are there, and it is completely communicating with the cysternal cavity. So what we plan is we try to like pack this defect with fat graft and try to put some suture. So in these kind of cases, if it is not a redo surgery, if there is no radiation is there, then it is quite easier to approximate the dura and completely close the dura. And there was some because post radiation we cannot close the dura completely. So we put few sutures. We try to like approximate the dura, and once the dura is like approximated, then over it we do the same thing. We also suture the facilitator graft. Because there was no possibility in this case to take nasoseptal flap, and the middle turbinate has already been taken out on either side. So we had only the inferior turbinate, and in this case, we decided if the patient will have leak, then we may have to harvest the inferior turbinate to use the inferior turbinate as a rescue method. This particular patient has postoperative CSF leak on day 3, and we put lumbar drain and keep the lumbar drain for 5 days. And after that, clamping of the lumbar drain didn't resulted in postoperative the further CSF leak, and we removed the lumbar drain, and the patient did well. So these are few case scenarios, and the cases have been shown that these are different methods of closure and to prevent the postoperative CSF leak. And now we are analyzing. So this is my personal series of almost 248 cases from 2020 to 2026, where we found that intraoperative the arachnoid breach is there, or there is the grade 4 CSF leak. So without suturing and with suturing, when you compare, now the number with suturing is more than 130. So we found that the kind of cases are almost similar, and the type of the intraoperative CSF leaks are almost similar. So when you compare without suturing versus with suturing, when we use 1 or 2 sutures, that significantly reduces the immediate postoperative CSF leak as well as the delayed postoperative CSF leak. The postoperative infection also dropped down, and use of other medications, lumbar drain, and redo surgery has also significantly dropped down if we are not using this suture. And the mean hospital stay has also dropped down from 9.5 days to almost 6.5 days if we are using this additional measure. So there are different like methods that are used, and different methods are being practiced. There are heterogeneous practices there, but whatever best is there, we can use to prevent CSF leak. So to conclude, intraoperative prevention of CSF leak probably is the best way to avoid a postoperative CSF leak. And a multi-layer closure is already tested, already described in so many series, and wherever is possible, we should use all available methods to use the multi-layer closure using an nasoseptal flap. Dural suture, yes, if it is possible. And we have also we believe that if it is possible, we can use it. It is very helpful for the extended skull base technique. And if the postoperative CSF leak is happening, then using a lumbar drain is already proven to be effective for the high flow leaks, but may not be needed, and it is very controversial for the low flow leaks. But again, if it is not settling down with the lumbar drain, and with lumbar drain, if the patient is already having some CSF leak, then one must consider immediate repair of the skull base repair. Otherwise, the patient may land up with meningitis. And if it is like the CSF leak will settle down with lumbar drain, then it can be taken out. So there are different ways of handling of CSF leak intraoperatively as well as postoperatively, and we have also varieties of methods and varieties of practice. There is no consensus in this regard. So whatever waste is there, we can use them to prevent CSF leak. Okay, thank you.
Thank you, Sushant. Once again, I'm greatly fascinated by your suturing technique, and been trying to replicate what you've been doing in intranasal suturing. But I do feel that it is an extremely useful technique for reducing the extent of skull-based pulsations that can drive the graft away. So thank you so much for your talk. Now we have Dr. Akhilesh Gowda, who shall be presenting two cases for us. And this is, I'm hoping that we panelists and speakers will be able to tell us how they would like to manage the scenario when they face this in their own operation theaters. This is, uh, I hope this will be a more interactive discussion. So Akhilesh, you can start your slides, and then you
Yes,
can
sir.
stop at the points where you want to ask questions.
Yes, sir. Good afternoon, everyone. Am I audible, sir?
Yes, yes, yes.
Yes. Thank you for the opportunity for both from to NSI and NSE committees. Myself, Dr. Akhilesh Gowda from Sri Chitra Hospital. Today, I'm going to take you through some of our own experiences of endoscopic skull-based surgery mishaps or complications through some case capsules, so that this session will become more interactive and we can learn from this. Coming to the case we went first. This is a 25-year-old gentleman presented with complaints of headache with progressive visual blurring for 2 months. And he had also complaints of progressive enlargement of both the hands and feet and coarsening of facial features. And these complaints were there since 6 months. And he was evaluated outside and referred here. On examination, he had bitemporal hemianopia and features of acromegaly, and other systemic examination apart from acromegaly thing were not remarkable. And on pre-op investigation, after coming to our institute, he found to have raised growth hormone levels and also IGF levels, and he was evaluated by the endocrinology team, and he had lower limit of cortisol levels, and he was supplemented through steroids. And we subjected him to CT scan. The CT scan was suggestive of predominantly cellular lesion with supracellular extension, and also this lesion was compressing the optic chiasma, and we are able to see all the acromegaly features and thickening of the bone on the calvarial bone and thickening of the soft tissue, and also the well pneumatized aerated sinuses. And in this axial CT also we can able to see very well aerated pneumatized sinuses and post-cellular type of pneumatization, but there is no true bony dehiscence as such. And after this, we did subjected him for say MRI scan. We confirmed the diagnosis. It was a supracellular lesion, predominantly cellular lesion, but extending anteriorly and pressing the basifrontal lobe and also elevating the optic chiasma, left sided predominantly gyrus rectus, and cavernous extension was also there in the left side. And this is the contrast enhancing lesion with ISO 2 hyper intense lesion, which is encasing partly the ACOM complex and also going to the left side, but it is displacing the cavernous and medial cavernous sinus wall, but there was no true cavernous sinus invasion as per the scan. And I would like to ask after this, like our institution follows, there is a checklist for all the pituitary endoscopy skull-based surgery patients who are undergoing. Like what are the like things we should look for both in CT scan and also MRI scan, in especially a index case we are going to approach through endoscopic skull base surgery or it's a reverse surgery.
Maybe Diego, we can start with you. Are you here? Diego, are you online?
Yes, I
Yeah.
am.
So, any comments on Dr. Akhilesh's slides?
No, I think that the neuroradiological workup is complete. I believe I agree completely with the colleagues. This is a first hypothesis, a macro GH secreting pituitary adenoma with a cellular and supracellular extension. It's more difficult. It could be dangerous in supracellular part because I am not sure, but because it's very little the images in my PC, but I believe that could be relationships between the dome of the tumor, the supracellular dome of tumor, and the A1, A2 complex, maybe. I'm not sure. Maybe it could be interesting T2 weighted sequences, coronal view and sagittal view to understand this aspect. It's very, very narrow. I don't understand what is the very upper intensity lesion very close to the gyrus rectus in the upper part of the tumor. But it's a limit of my visualization in my PC. But I think my first hypothesis is GX secondary pituitary adenomas could be removed by transsphenoidal transtuberculum extended approach. Following, maybe it could be better performed the angio-CT scan to know very well what is the relationship between the tumor and the A1, A2 complex and carotid arteries.
So, Akhilesh, you can go on. We can
Just
go on to the video of the procedure.
Yes, sir. As Professor Diego sir correctly mentioned, after this investigation, we subjected this patient and to approach this tumor through endoscopic endonasal approach. Our institution follows a policy of wide anterior spinodotomy from blue to blue, either lateral and also from anterior to posterior. And since the lesion was also going into the anterior superior side and involving the A1, A2 complex and also compressing the left side of the gyrus rectus, we wanted to expose completely uh, expose all the cellular floor and drill the complete cellular floor, and also to drill that go into transtubercular area so that we'll get the wide panoramic view of the tumor in order to excise completely, since it was a functional pituitary tumor. And we can able to see that completely we remove the cellular floor, and also we are going to drill on the left side of the cavernous sinus anterior bony wall, so that we are able to see the cavernous sinus, because the left side there was an invasion query. And we drilled it tubercular crest also. And while drilling, we are able to see there was a small dural tear because of small dehiscence of the bone, and bone was very thin. And like, how would you like to proceed when there is a dural tear? Because sometimes we experience this whenever we use transnasal birth, there will be wobbling of this drill, coming going to and fro. Like, any comments, sir, to the panelists?
Sushant, would you want to make any comments?
Yeah, actually, what we do is we we do something different. Like I start the drilling from the center and take out the bone, and gradually with the dissect it from the dura anteriorly. Particularly while going anteriorly, I try to dissect some amount of dura from the bone, and with a Ronja half cut, we try to just take out small pieces of bone, because this is slightly dangerous actually. While drilling, there is a high chance if it is other end, then there is a the dural length will happen.
Yeah, quite true, quite true,
Yes, sir.
quite.
that
Shall I
it's not
proceed,
a
sir?
problem to create a dural damage because in case of
Yeah.
a supracellular lesion, you have to manage with the extracapsular technique. So your goal in tumor removal is first of all remove the central part of the tumor, and after control the dome intradurally. So the extension transtuberculum approach allow a intradural space. don't complain you are dural damage because you have to work intradurally to remove radically this tumor. Because in case of GH-setting pituitary adenomas, we have to plan a surgical procedure allowing a gross total because the surgery is able to cure also the macro GH secreting adenoma. So going on, and there is no problem, in my opinion, to damage the dura mater supracellular space. You have to work behind.
Yes, sir. It's true. Shall I proceed, sir, further?
Proceed.
Yes, sir. Further, while drilling, we would have rounded the bony spicules, the thin wall, but we had a encounter near to the left medial opticokeratosis, probably from the clinoidal ICA area. We had a torrential bleeding, and to the panelists, like after encountering this catastrophe, like how would you like to go ahead? Uh, because we have like after like before the procedure, like since it was not extending more towards the para cavernous area and cavernous sinus was completely not involved, so we didn't expose the neck. We just went into a standard procedure by exposing thigh fat and wanted to take muscle if in case any bleed. Like how will you proceed? Like what would have further we would have anticipated?
So Dr. Akhilesh wants to know how you would, now you have an ICA injury, you have a bleed coming from the ICA. How would you
Yes, sir.
proceed at this point of time?
Yes, sir. Like we'll try to localize exactly where the bleed from, whether it's from a cavernous sinus or a clinoidal IC or a
Akhilesh,
branch of.
you can answer this after the panelists. So
Yes, sir.
we'll give Diego and Sushant a chance to tell us how they would like to manage this.
I don't understand because the maneuver of drilling around the cella turcica is really dangerous. In our technique, we use the drilling only in case of not so well pneumatized sphenoidal sinus. In case of like this, you can open safely or more safely the sella turcica with the Carrison Roger. It's very easy and strictly in the midline, according to between the two optic carotid medial recesses. After you open the bone, the sella turcica, you move up. In case of you need use the drill, you know very well the lateral extension of the bone removal. Conversely, I have seen you performed a peripheral osteotomy very close to the optic carotid recess. So this is could be very dangerous because you don't control behind the bone the dura madre. You enter directly in the paracellular space. Also, if you remain medially to optic carotid recess. First. Second one, in this case, could be really dangerous because we don't control anything. The vessel, the ICA is behind the bone, behind the dura. So could be happen also in subarachnoid hemorrhages. So it's very, very dangerous. So in this case, it's better to control immediately with packing and move to interventional neuroradiologist that before perform immediately CT scan because it could be necessary also craniotomy and also drainage of ventriculostomy. This is a very dangerous situation. You are bleeding, but you don't know where is the bleeding. You
Will
see
you
only the blood come out.
will you pack it with only patties, or would you like to put fat or muscle on the suspected area of the rent before you take the patient for angiogram?
Yes, it's not important which you use, fat, bone, packing. It's important to control the blood pressure, maintain stable the cerebral perfusion, speaking with the anesthesiologist, and move quickly because you are never under control. You control anything in this situation. So prepare neck, etc., is after the diagnosis. Where is the damage of the internal carotid artery? I believe in the medial wall of a carotid artery in this cavernous sinus. It's more probably, but I'm not sure because I don't see where is the most dangerous situation.
Sushant, what are your comments?
I also totally agree with Professor Diego, the way he also told that. I also believe that. So we have to be slightly like cautious while going to those places, because in acromegaly we need to be more aggressive in taking out the entire tumor. So it would have been like drilling from the center, going to the periphery slightly, as I told that delineating the margin of the dura and the bone. You have to be very careful. And once we see the some bluish, then we have to stop rather than trying to go further. And coming to the second question, as you asked that the how to pack it. So initially we do not have muscles actually. So whatever is there with the patty, we have to just pack it and just to wait. If the bleeding will stop, of course, we have to shift the patient. If the patient need to be hemodynamically like stable with our anesthesiologist like consultation, then immediately patient has to be shifted. If the bleeding is not getting controlled with the cottonettes and it is coming out, then we have to take out some muscle patch. Then you have to put muscle over that defect. Then the cotton, then got is to just pack it and without wasting much time, because these kind of patient, if you wait for a slightly waste time, then there is a chance of hemodynamic instability, and that will be like adds like perfusion injury may happen. That is my concern.
So, Janvi, as the as a ENT surgeon who's assisting a neurosurgeon, what would your suggestions be on, how appropriately you can handle the field at this point of time?
It's usually at the point where it starts bleeding that this entire scope goes out of view. And that's when suddenly all the suction stop working, the bipolar stops working. We don't know where the point of the bleed is. But yes, as the surgeon who would be holding the scope, the main point for the ENT surgeons here would be to try and give a good view and find out exactly where the bleeding point is. So, a good irrigation possibly at the point of bleed, while maybe the fat is being harvested or the muscle is being harvested to try and identify where the bleeding point is. That would be one of the main things.
So, do
And
you
in
also
this
bring in
case,
a large bore suction in addition to the
yes,
suction that is
large bore
already there in the
suctions, and
field?
usually we try to keep 3 suction tubings ready.
Correct.
Yes.
So, Akhilesh, you can show us what happened next.
Yes. Yes, panelists rightly advised and mentioned the further steps commensurated by initiating the emergency code and alerting the anesthesiologist to keep the BP high, and also calling for helps so that all hands will be on the deck. And we try to visualize the bleeder while taking another set of wide bore suction. We actually use 3 suctions for any endoscopic skull base surgery. And there was a bony speckle which is uh, uh, masking the exact site of bleed. So we packed and we ronged the complete bony speckle so that we can able to or pinpoint the site of the bleed. And after that, the bleeding propensity is somewhat less, and we irrigated properly, and we are able to localize the correct site of bleed. It was from the clinal portion of the ICA, just above and lateral to the MOCR left side. And meanwhile, the other team which called for the hand who took out the muscle patch from the thigh, and we were able to uh, pack with the muscles, and also from the hemostats like Surgicel and new knits, and also intermittently tamponing with the gauze patties, and we are able to completely able to control the bleeding. Once we control the bleeding, further we augmented the packing area with further more muscle tissue, and also with some more units and put glue, and also we abandoned the surgery and we buttress this area of packing with the already pre-harvested adult flap, and also once patient was completely all right, and patient was on we decided to take him to the cath lab, and we informed to the relatives, and subsequently patients took into the cath lab, and after alerting the neuro intervention
Well,
on
here
that same. Yes, sir.
one reason we decided to put muscle and a graft was because we could then avoid the chance of patient being brought back for pack removal. The bleed had stopped with some amount of pressure, so the muscle kind of augments the healing over the vessel also. And so this was the thought process behind putting the muscle and placing the flap before shifting the patient to the DSA room. However, when the bleeding is extremely torrential, then this is often not possible. But we were able to do it because we were able to secure the this. But the lesson learned from this is one, as Diego mentioned, the area of drilling should have been extreme. We should have been aware of the fact that we were drilling on the ICA, and the fact that we had gotten venous bleed prior to that was something that should have alerted us the possibility that now the ICA wall was directly in contact. So with this, Jadavan sir, I think we'll take your opinion next on how we should now proceed, because now the patient is being wheeled into the cath lab, and you are being informed that there is a patient coming who's had an IC injury, suspected IC injury on table. So what would your suggestions be on how you would like to manage this next?
Yeah, well, this actually I remember this case. So usually we do all these cases under heparinization. So in this particular scenario, we just keep the heparin on very low profile, only the infusion only in the devices we will pass, and we will complete the angio, and some cross circulation study we will do, and complete 3D angiogram, because very small pseudoaneurysm in a 2D angiogram it will not be possible. So we have to do 3D angiogram, any small elevation from the wall and everything we can identify it. So if anything is there, a suspicion of pseudoaneurysm or anything, then we can manage it accordingly. So it seems it is a relatively young patient where these what is that coverts and negotiation is rather more easy. So if any doubtful or any definitive pseudoaneurysm is there, we can put a coverts in that area, and after that we can put him on a dual antiplatelet. But if anatomy is quite difficult, then it is going to be a challenging thing. So where we have to use multiple options, whether that pseudoaneurysm is coilable, or we have to put a stent-assisted coiling. So most of the time, as a ongoing bleeding scenario, immediately from the OT, so we see that whether it is a stent, the stent graft that covers, and whether we can place it or not. That is the first option we usually think. Otherwise, if it is not possible, then only the other option. Then, if the sacrificing is possible by the collateral circulation, definitely we will go ahead. Just we will never do a balloon occlusion test. Just see the cross circulation, venous delay, then we can proceed. So that is a usual thing we have done that. But in this case, I think I remember that even after doing multiple runs and multiple 3Ds, we couldn't find any definite rend or any elevation or a kind of something suggestive of pseudoaneurysm there.
Yes, sir. Sir, I have a question. Like for young neurosurgeons like us and a lot of residents over here, should we like make a necessate a DSA or like proper digital subtraction angiography with carotid this balloon occlusion test, all for not for like extensive tumors. Extensive tumors we use that. For simple tumors also we should include in the protocol or as a checklist before surgery.
One thing is that a balloon occlusion test is a very significant complication rate is there. So
Yes,
we generally don't ask for a balloon occlusion unless it is really wanted, because in a scenario where we are expecting a carotid tear, like initially I explained, the very completely encircling the carotid, or a very large tumor, or that is acromegaly, or long-standing bromocriptine, those kind of thing, which is the tumor is encasing. There we can do it, but in a regular basis, doing a balloon occlusion is not advisable, because it carries significant complication rate risk. That is one thing. But what we can what we can do is we can do a CT angiogram and see whether the primary collateral like ACOM and PCOM, how are they? Do they have a normal size? Are they complete? So if you have a good primary collateral like a PCOM and ACOM of size more than a millimeter, this will adequately support in case if you want to occlude any of this vessel. So at least a CT angiogram would be better rather than doing a balloon occlusion test. Of course, the DSA with a cross compression study we can do. That also we will give, it will give a better idea regarding cross circulation. But manual compression usually won't give a adequate information about the adequacy of the cross circulation.
Collateral flow. Yes,
But
sir.
most of the time we can get away with a CT angiogram in this situation where we are not really not expecting any complication.
Understood, sir. I agree, sir.
We go, Sushant, do you do a CT angiogram for all your patients who are planned for endonasal skull base surgery?
No, not all, not for all. In case of invasion of cavernous sinus, always. In case of the suprasellar lesion, if the MRI is very clear to demonstrate the relationship between the dome of tumor and the Willis polygon, it's okay. Conversely, we prefer to perform a quickly angio-CT scan because you know all the structure of the bone and also the vascular structure is the perfect for the approach. So it's a very quickly, you can perform 10 minutes before also the surgery. It's not so invasive procedure, 30 seconds. You achieve full information to proceed more safely than without. But in a standard adenoma, no. In the standard pituitary adenoma,
Actually, what we do is, as you told that for extended cases, yes, if there is cavernous sinus invasion is yes, those are the classical indication to do like angiogram before this. But particularly in acromegaly, we have seen few cases, they have additional aneurysm formation. So we made a protocol in our center for acromegaly particularly. We do CT angiogram in routine, and we have found that not related to tumor also. We have found that MCA bifurcation aneurysm, ACOM aneurysm, A1 segment aneurysm, also in cavernous IC aneurysm, not related to tumor as well as not related to tumor. So mostly in case of acromegaly. So probably we need some multicentric or large volume cases to just analyze whether this is just a finding or there is some correlation is there.
No, this
But
is
yes,
true.
we do.
This is true. We have also found patients who have coexisting aneurysms in acromegaly. And I have also heard some other centers where they have also noted this, not on a very large basis, but they do occasionally see patients with acromegaly who have a coexisting aneurysm. So I think one more take-home lesson for a lot of neurosurgeons is that when you do this packing, the packing should not itself compress the ICA. And this is often seen when you have exuberant packing being done on an ICA that has already been skeletonized. The packing can also compress the carotid artery and can cause stroke. So, Akhilesh, can you go on and show us what happened next?
Yes. Immediately, patient wheeled into cath lab after alerting neuroradiologist, and but the patient vitally was stable, and patient was under anesthesia. And on DSA, we did digital subtraction angiography, but there was no pseudoaneurysms was noted in the current scan. And since the patient's vitals were stable and cardiovascular parameters are normal, we extubated the patient on the same day, and he was doing fine. Like if there is no pseudoaneurysm or no whatsoever, like injury footmarks were not visible in the scan. I'm asking the panelists like what should we do next? Like if there is no pseudoaneurysm was demonstrable.
Definitely, early imaging is required. Even with the pseudoaneurysm, even without pseudoaneurysm, early imaging within 4 5 days or a bit before 1 week, we have to do an angiogram, either DSA or CT angiogram. Even if you see a pseudoaneurysm and you have packed it, that also requires an early imaging because that will progress further and it can rupture. Of course, early imaging is very essential in all these situations.
So one point I want to make, like particularly in these kind of cases, majority of times what we found is that just after the bleeding, immediately we do not get anything. Like the pseudoaneurysm formation, it will take some time. Immediately the vessel wall, slight irregularity of the, apart from the slight irregularity of the vessel wall, nothing is there. Everything is normal. So some 8-9 months before, I have a similar case. So while taking out the tumor anteriorly, there is some rent is there. In immediate post-operative period, immediately the patient was shifted and there was no severe aneurysm, nothing. And on post-op day 4, patient had a significant leak, the significant hemorrhage, and there was significant hematoma. So probably the aneurysm formation may be taking some like 3 to 5 days. So what we feel is that in these kind of cases, if there is nothing is visible in the immediate DSA, then we should do some angio on day 3 or day 5, just to look for there is if there is any progression of the or formation of the pseudoaneurysm. Probably that may help. And if it is not there, then of course it has to repeat it just before the discharge, and as you told, that in a regular interval.
Yeah, at least after 3 days, better to get to on a CT angiogram. Definitely, it will find some relevant finding, which is pseudoaneurysm is developing, because the surgeons are very confident that they have touched the ICA. So definitely, it has to be done on 3 days. Still, if it is not forming after 1 week, also it has to be done. So very frequent imaging, at least the early stage, we have to do that. Definitely, it is required.
Akhilesh, go on.
Yes. As Sir Jayadevan sir and Sushant sir rightly said, we had a doubt, like it was too early to detect in a DSA. So, but the patient was doing fine, and he was actually a young patient. We didn't discharge the patient, and we planned him for 7 day vessel wall imaging that was planned for CT angiopria. But however, on the post-operative day 6, patient had sudden deterioration of left side left side vision. He had sudden deterioration, and he was immediately subjected to the CT angio. And in CT angio, we are able to see this is the recon image. We are able to see the arrow marks showing the pseudoaneurysm arising from the dorsal wall of the ICA, and also in the sagittal image showing the pseudoaneurysm, which was around 5 size. And patient, since he had sudden deterioration of vision, we immediately taken him for surgery, since our goal was to save his left eye, and also to decompress the tumor as much as we can. Any comments, sir?
So how would you proceed at this point of time? You have a patient who now this patient was actually planned for elective DSA a day later, but
Yes, sir.
he suddenly complained of visual loss. We did a CT angiogram. We've seen this aneurysm now. And obviously there is some hemorrhagic change also probably going on in the tumor. So how would you proceed at this point of time? Diego, Shan,
So it was on post-op day.
Sorry.
Which post-op day it was detected actually, the deterioration?
Day 6, sir.
Day
Post-operative day 6.
6. No, it
Yes, sir.
is similar findings. We have also noted that the pseudoaneurysm or the bleed usually happens after 3 days. So as a routine, just an opinion. As a routine, one angio has to be done at 3 days, 3 or 4 days. So there is no need to wait. Similar, we did one mistake. Like there was some injury, and we presume everything is normal, and before discharge we will do the angio, because we discharge at day 8 or day 10, and the patient had a bleed on day 6, and we lost that patient. So what I feel is that on day 3 or day 4, that is one point to just look for if there is any numbing is there. If it is detected early, then of course the neurointervention team, they can do the best actually. The options are there, so they can find out what is best for the patient. And if
Sushant,
it is not
in
there,
this
then of
case
course.
now you have a patient who has an aneurysm. How will you proceed? Will you do a transcranial approach? Will you coil the aneurysm? He's got visual loss now. Or will you plan to
No,
keep the
but
aneurysm? clip the
For
NT1.
for this particular case, because visual loss is maybe because of the compression actually, as it is showing, so maybe the aneurysm is compressing for the pseudoaneurysm. And clipping of the pseudoaneurysm is slightly challenging. We can do a muscle wrapping, and over that muscle we have to apply a clip just to hold this. And I feel that yes, clipping should be preferred because visual loss is there, and it may be because of the compression. That is one. So coiling of that may not help. And again, in pseudoaneurysm, coiling is again. I think sir can reply about this, that a flow diversion and coiling what can be the best option. But yes, surgery should be considered because the visual loss is there.
Yeah, as Saras mentioned, since it is a compressive symptoms are there, generally we don't prefer for endovascular option, and also it's a so small pseudoaneurysm. Looks like the recently acutely developed aneurysm. In this kind of small pseudoaneurysm, when we coil it, intra-procedure rupture rate is very, very high. So generally, we don't prefer to go for coiling. We put a flow diverter only. But in this scenario, since the compression symptoms are there, generally we ask for a surgical management rather than a endovascular management.
So Akhilesh, you can tell us what we did, and then we can go on to the next case. We have
Yes, sir.
really coming to the close of.
Yes, sir. Yes, sir. Sure. As panelists and rightly pointed out, since patient acute compressive symptoms and patient relatively young, and we wanted to give completely that since it was a pituitary functional tumor, we patient subjected the patient for left transcranial procedure, that is left terminal craniotomy, and we did the intradural craniotomy, and also it was actually pressing the optic nerve on the left side. And while dissecting, we had an intraoperative aneurysm rupture. And since it was very difficult to clip and it was very small aneurysm, we wrapped with the uh, muscle, crushed muscle, and also with the hemostats. And after that wrapping, and we did the gross total decompression of the tumor. And immediately patient was extubated on the same day, and patient was doing fine. However, the vision was improved gradually, and he had a biochemical remission, and HPR was somatotroph pituitary neuroendocrine tumor, and he's on clinical follow-up and radiological follow-up to OPD.
But
Yes, sir.
using a muscle patch in these cases is extremely useful because muscle helps us in keeping the clip, and difficult scenario for both the surgeon and for the endovascular surgeon at this point of time. So we can go on to the next case.
So
Yes,
just
sir.
one point that I would make in this case. It's a patient with an. Can I speak for a minute, sir?
Sure, sure.
Yeah, just one point I would like to make. Actually, all these acromegaly patients we have seen, their turbinates are really huge. The nose would look big from outside, but the space is very less inside, and maneuverability of instruments is very difficult. So, in these patients, if we are actually planning to drill on the carotid canal, we need to make use of that lateral pneumatization of the sphenoid and actually do an exposure even beyond the LOCR. That is what we usually try to do, get a good exposure even beyond the LOCR on both sides before drilling lateral to the sella, and also a retrograde posterior ethmoidectomy so that the maneuverability of instruments becomes very easy. Thank you.
So, Diego, would you think of another repeat endonasal procedure in this patient, or would you think of a transcranial procedure? I mean, just before we go on to the next case. Diego, would you think of a endonasal procedure or a transcranial procedure for in this scenario? Akhilesh, you can go on to the next case.
Yes, sir. This is I'm presenting now case capsule 2. This is a 23-year-old gentleman presented with headache and visual disturbances. On past history, he had delayed puberty and also short stature. And he was outside, he was worked up in outside. It was showing a cellular supracellular cystic lesion with pan hypopituitarism. And on examination, he had bitemporal hemianopia, but left eye was severely involved. However, you were able to count the finger on both the nasal sides in the nasal side in both the eyes, and he had features of hypogonadism also. This is a CT scan which was showing cellular, predominantly supracellular lesion, hyperdense lesion, with the post-stellar type of pneumatization. And this is the T1 image of MRI, which showing predominantly supracellular lesion, which is compressing the optic chiasma, hypothalamus, and also mammillary body, and tuberous cinerem is compressed and displaced posterior superiorly. And also there is a doubtful good plane between the hypothalamus also, and it is just projecting into the floor of the third ventricle, and it is playing the inter peduncular space and also mm, displacing the midbrain. And this T2 also, T1 it was hyper, and also T2 it was hyper. So the diagnosis, there was no proper calcification, but some speckled calcification was there found on the cellular floor and also towards the periphery of the lesion. And there was a heterogeneous contrast enhancement of the lesion, as we can see here. And since the patient was having favorable pneumatization and also not its completely tumor was intraventricular, and there was a appearance to be good plane around the hypothalamus, and it was a retrochiasmatic lesion, patient was subjected to extended endoscopic procedure. Any insights or comments, sir?
So, Sushant, Diego, how would you proceed?
I agree completely with your choice. This is a craniopharyngioma. It could be operated through transnasal, transtuberculum approach. Position of A1, A2 complex optic chiasm is favorable. Well pneumatized phenoidal sinus. Symmetric cystic lesion. My first choice is endoscopic transnasal extended approach.
Sushant?
Yes, agreed. Actually, considering it is a cystic lesion, yes, endoscopically, yes, it is possible. So two factors are favorable. One is pneumatization, one is cystic. So I think we should go ahead with extended endoscopy.
Akhilesh, proceed.
Okay, sir. Rightly, we subjected this patient for extended endoscopic tubercular approach, and we did intraoperatively. We found that there was not a good plane between the hypothalamus in order to avoid post-operative morbidity. We did a maximal safe decompression, removing the little bit of a capsular wall on the hypothalamus, and we did a maximal safe decompression and under the lumbar drain incision. Since time constraints are there, I am not going through the procedure steps per se. And immediately, procedure was uneventful, and patient had this was a post-op CT, which is showing pretty good scan with some pneumocephalus. Sorry, and we are able to achieve a good amount of decompression, and there was no any SCH or any vascular signs of any vascular insult, and patient was uh, coming out of the anesthesia, was subsequently extubated on the same day. And for first few days he was doing fine, but however on the post-operative day 8, except for there was no any major warning signs or red flags, but he had some fluid and electrolyte disturbances which was managed medically. However, on the post-operative day 8, patient had a right-sided hemiparesis and also aphasia, and the patient was immediately taken to MRI and CT scan, and subsequently there was a hypod density lesions on the left thalamus, left central semi-ovale, and also towards the left medial part of frontal gyrus, part of the middle frontal gyrus, and he was subjected to uh, this
So, at
MRI.
this point,
Yes, sir. Yes, sir. Hello.
patient who's got features of acute stroke on day 8 after surgery. So he's been doing well after surgery without any deficits.
Yes,
So
sir.
how would you proceed at this point of time?
I think this case was discussed, na? That is case of vasospasm.
Yes, yes.
So,
Yes, sir.
particularly
I
for
agree.
this cystic craniopharyngioma, so exact nature of the cystic fluid is not known. In few cases, we have tried to analyze the cyst fluid. A delayed, not very delayed, but in the same admission, we have seen this vasospasm in open as well as in this endoscopic cases. So whenever there is the in endoscopy, so in craniopharyngium, we need to go extra arachnoid. So spillage of the cyst fluid into the subarachnoid space is very common in these kind of cases. Probably this cyst fluid, the high proteinaceous cyst fluid, somehow they induce vasospasm in some cases, not a very routine finding, but in some cases. So this is known, but already infarction is there. So we need to be very conservative. Nothing much can be done. Yes, of course, we can do DSN to find out where the how the spasm is there, but you cannot put much of the vasodilator. No, it can induce like further hemorrhage into the infarct area.
Diego, do you have any other suggestions?
No, I agree completely with Dr. Saho. This is a vasospasm in post-operative day 8, obviously. There is not evidence in CT scan in the same day of surgical procedure, obviously, because it's occurred 7, 8 days after. Could be happen. I agree. The cystic liquid inside the cavernous pharyngioma could be provocate a vasospasm in a subarachnoid space, obviously. It's a complication of this type of surgery. It not depends of a surgical technique.
How do you manage this?
Some
If you encounter this, how do you manage this in your center?
in we use the a vasodilatator, obviously. In this case, it could be also answer in balloon for vasodilatation of big vessel. It depends of surgical skills of the neuroradiologist. But our first choice is medical treatment of vasospasm. Second step, balloon intravascular. But I believe that it is very focal lesion perforated, so it's very difficult to use the endovascular technique. I believe I'm not a neurovascular surgeon. I'm not an endovascular radiologist. So, and but at the, with this MRI, I see a consolidated damage. Unfortunately, it's very, very well defined, the lesion. So maybe it's too late, but we can, and the war, it will, don't forget the second step is inversion of the ischemic lesion, could be then more dangerous than ischemic alone. So take care.
So, Dr. Jaydevan, would you tell us more about the management of vasospasm that we see after surgery?
Generally what we see is aneurysmal vasospasm. What we generally manage is vasodilators. Generally, as a protocol, we use milrinone. Milrinone is usually when we use around 8 to 6, 15, 16 ml. It's fairly open. For even one vascular territory, if you give, it will open the other vascular territories also. And most often it opens. And generally, we don't proceed to balloon angioplasty in a first scenario as in a SAH case. But in this kind of this tumor, like craniopharyngioma, it's not just because of the blood alone. There are some other pathologies also there, which makes the opening of these vessels by milrinone alone may not be sufficient. And sometimes it will be quite resistance. It will open slightly and immediately it will close. So in the first option itself, we may have to open it slightly bit and then you pass the balloon and open it up. Otherwise, again, it will come back with a complete occlusion. Then further, we won't get a passage to pass the balloon even. So this will be just like a little resistant vasospasm. Usually it will be.
So, Akhilesh, can you go on and tell us how this was managed?
Yes, sir. As the panelist rightly pointed out, it patient had a vasospasm, that left thalamic stroke due to vasospasm, and patient immediately was wheeled to cath lab, and we did a DSA. It was showing a smooth narrowing of the both the anterior and also posterior circulation, and on both the sides. On the right side also, we can able to see the smooth narrowing or tapering of the ICA, and also along with the ACA and MCA. And posterior circulation also, we are able to see the tapering of bilateral PCA along with the basilar artery. As Jaidevan sir rightly said, since patient was young and he had a specific territorial infarct, he was subjected to chemical angioplasty. That was given milrinone. This is the post milrinone injection. We are able to see the near opening of that both ACA, MCA, and also the ICA. And since patient had two settings of milrinone injection and also along with balloon angioplasty to keep the both ICS and also AC and MCS open. And patient after this two sittings of angioplasty, patient was continued on milrinone infusion for further 14 days. And also his weakness was improved, and also he was improved of his aphasia gradually, and he was discharged after 3 weeks after hospital of admission. And the clinical HPR report was adamantinomatous craniopharyngioma, WHO grade 1. And is kept on currently follow up both clinically and radiologically, is doing well.
So one of the aims of presenting this was to tell you that we've encountered a few cases, both for patients with pituitary adenomas and craniopharyngiomas, where very early intervention before they develop any significant deficits are actually reversible. And we treat them very aggressively with the help of Professor Jaydevan. We treat them very aggressively with therapy. We send them for early angiograms. The problem is some of the young patients, especially, will have may require multiple treatments. So you might need to do the same 2 or 3 times. But their outcomes are very good, and they usually recover without any new deficit. So, for example, this patient had developed aphasia and weakness, but the weakness had reversed completely. And by the time of discharge, he had no aphasia or weakness. And now, at nearly a year of follow-up, he does very well. We had published one of the first case of this sort in 2016, where we had a similar patient who had developed left NSI territory spasm and had been reversed very successfully with a single management with endovascular treatment. So this is probably unrecognized and probably needs more and more attention at some points of time, especially for early visualization of the stroke using an MRI and then management with endovascular treatment. So we have one question in the chat box from Dr. Gautam, who wants to ask us if in the first case where we showed an aneurysm that happened out on day 4. So he is asking us if DSA was negative the second time around also. So for example, suppose the patient did not have an aneurysm. So would you like to consider an endovascular treatment, an endonasal resection for that patient? Suppose the patient had a repeat DSA on day 6 or day 7, which did not show an aneurysm. Would you consider a resection through the endonasal route rather than a transcranial route?
Actually, it is tricky because already you have some bleed. If you go from the same place, we knew that already some bleeding already happened. And going from endonasally, because the vessel, the point of leak, we are not very sure. If again suppose the bleed, again suppose there will be again bleeding from that side. So we should have all the gadgets how to like control that bleeding. Because some pseudoaneurysm, some vessel wall change must be there after few days. So you have to prepare for the control of that bleeding. So considering all these, I think endonasal will be a dangerous one. If you transcranial, then you can plan for your like all these like the control of the vessel that you can plan anyway. But endoscopically, control of those vessels will be extremely difficult. So personally, I will not prefer for that, although we can debate.
Suppose this patient did not have visual loss. Suppose he remained clinically stable for the next few days. Would you plan a delayed procedure, maybe after 1 month, using the endonasal approach? Diego, would you think of an endonasal approach maybe after 1 month if he had no worsening of his vision?
No, then what about the pseudoaneurysm? Suppose there is no worsening of
Suppose there
vision,
is no pseudoaneurysm.
no aneurysm. Okay.
Suppose you
So
repeat
then,
a DSA, there is no
uh,
aneurysm, and your patient is clinically stable. Would you
okay.
plan a repeat surgery through the transcranial route? And when would you plan it? Or would you still plan an endonasal approach, and when would you plan it?
Actually, I don't think we have to search the literature. If there are some series or something like that is there, if there is no pseudoaneurysm information or the DSA is negative, then how long we have to wait? But I feel waiting for 3-4 weeks is good enough. If it is not forming, then delayed pseudoaneurysm or delayed aneurysm formation is maybe relatively rare. But yes, we have to be take care. The point what I mentioned is once there is some bleed, again going to that point and doing the same maneuver, the risk of bleeding will be definitely there. So you should have some rescue method.
Diego, what about you? What was your opinion on this?
I agree completely with Dr. Sahu. This is a very, very complex situation. And don't forget, there is a several difference between a visual loss and a quality of life. Okay, don't forget this because, in my opinion, I can accept a visual loss, monolateral visual loss, without any major complication, worst death of patient. So, in this case, we can balance. In Latin, we use quod vitam, quod valetudinem. What does it mean? The visual loss is a very dramatic situation, but it's you can stay alive with the one hand. So it's case by case, patient by patient, speak very clearly with the patient, with the family, and you can offer the best solution. Sometimes it's not the best, but it could be a balance between the clinical condition and the quality of life of patient, because these surgeries could be very dangerous.
When you plan your second procedure, when will you do it? Suppose your patient does not have an aneurysm. Would you do it within the same hospital admission, or
No,
would you plan?
yes. Without aneurysm, I come back with the second procedure, and without any doubt, sure.
Within how many days? Would you do it in the same week or maybe a month later?
Yes, a month could be a balance. So longer to prepare the patient, but not so close to the events. So, but it's completely empiric because there are no evidence in literature. So this is a big problem. In this case, there is a very clinical practice and not empiric attitude, not very strong data with from literature. This is a big problem.
So I have a couple of questions for Dr. Janvi. Janvi, regarding your pack, how long do you ask for the pack to be retained? And specifically, one question regarding CPAP. So is there any recommendation that you follow regarding when a patient can start CPAP after the patient has undergone endonasal surgery?
So regarding the nasal packs, regarding the CPAP that you're saying, the patients actually usually we try to keep a nasopharyngeal airway like I showed in the video so that the patient does not immediately have breathing difficulty. But we have a problem when the patient is already dependent on CPAP prior to the procedure. So in those cases, if intubation is also considered, that it might be extubation might be difficult in those patients, and we have to keep the patient with a nasal pack, then we would have to consider a tracheostomy in the meantime, probably for about a week or 2 weeks, so that we can just tide over the period where after
If
two
you
weeks.
had a patient who's undergone successful surgery, suppose you had a
Yes.
small cellular tumor with no arachnoidal breach. You've done surgery now, the patient has been extubated, and the patient now requires CPAP in the post-operative setting. When would you recommend CPAP be reinitiated? After 2 weeks, 3 weeks, or is there a longer period?
If we've done a pedicle flap, we would wait up to 2 weeks, at least up to 2 weeks. We have had a patient which, after a clival reconstruction, CPAP was used for him after 2 weeks, and he had epistaxis for few days, 2 to 3 days after he started using CPAP, but which settled. We gave him another break of 48 to 72 hours. So usually we wait up to 2 to 3 weeks. This was a clival flap, and it was an extensive disease. So in other patients which with cellular lesion, with cellular excision, and probably just a small Hadad flap, I think up to 2 weeks would be the norm. We could start.
Is there any recommendation that you follow in Italy regarding reinitiation of CPAP in patients after endonasal surgery? Diego, question for you regarding CPAP.
I'm sorry, I don't listen. Can
No,
you repeat, please?
regarding CPAP. So, a
Oh,
positive airway
I
pressure.
stopped.
So in
I
Italy, do you have
stopped
any
the CPAP.
recommendation?
In patient, we use CPAP, I stopped. in extended approach, yes, it's impossible to CPAP. This is a question because I don't hear very well. What is the question?
No,
What is the question?
when do you
When you
when do you recommend restarting CPAP in a patient who's undergone endonasal surgery?
for transnasal transsphenoidal standard approach after 1 month or 50 days, maybe 2, 3 weeks, it depends. For extended, it's very difficult. Depends amount of the large opening you performed before. Because in case of a transtuberculum transplant or worse, transclival, the chip up is really could be really dangerous. It could be really dangerous. So 1 month at the least, in our experience, for chip up.
And one last
second question about the nasal packs, sir. So, in a patient who has had CSF leak and the reconstruction has been multi-layer and a pack has been placed, we usually wait at least 72 hours for the flap to heal, and following that, the pack removal is done.
think, are there any more questions from the audience that you want to ask? I think we have two senior neurosurgeons, Dr. Nishant and Dr. Avdesh, who are present here. Sir, would you want to make any comments? Avdesh, sir, Dr. Nishant, do you have any comments that you would like to make?
Dr. Prakash, every lecture was very good and very informative. I listened everything. Just I would like to say one thing that from February 26th, I have been also taking dural sutures, and actually I'm learning it, and it has really very helpful in preventing CSF leak. Number one, and about your this ICA injury during the acromegaly. Actually, you have done, you have tried clipping, but it's really very, I think, very difficult to do clipping in case of pseudoaneurysm. So, but also at the same time, if you do flow diverter, then you get double platelet, dual antiplatelet. So surgery would have been difficult. So it's a really very tricky situation. So if you ask me, then I think in that situation, I think there was something, some linear hyperintense thing was going in the tumor itself. So was that? Didn't you like that some angiogram should have been before in the workup of the patient? Dr. Prakash.
Yes. I didn't catch your question, sir.
Actually, that when the arterial injury was there, ICA injury was there in one of your patients, you showed the trachlea showed.
Yes.
So in that patient, if you see the preoperative imaging, T2 imaging, T2 preoperative imaging.
Yes, sir.
Coronal, yeah. In the coronal cut, you see a linear hypointense line. Don't you feel that it might give some suspicion of some vascular thing in the tumor itself?
This was an area of apoplexy. This patient had a CT angio prior to surgery. There was no aneurysm there. This was an area of apoplexy in the tumor.
Actually, if you see carefully, you will get a hypointense linear thing in the coronal cut.
That is also some area of bleed within the tumor, sir.
Maybe. But everybody presented very well, very informative. Thank you very much.
So thank you so much to all the speakers. I mean, I would personally thank Dr. Diego, Dr. Sushant, Jaydevan sir, Dr. Janvi for the time that you've taken and for willing to participate in the discussion. Kodishwaran sir, can I hand over the audience to you?
Yeah, it was a wonderful meeting. I enjoyed thoroughly. So the endoscopic complication, it was not dealt in so many meetings. So it was scary to see all these complications now. So any young neurosurgeons, you should not take all these things in lightly. So we have to do thorough preoperative workup, and also we should be careful during surgery also. So once again, thanks from NSI and NESI for everyone for joining this wonderful meeting. Congratulations, Dr. Prakash, for showing a good show. We had almost 50 plus participants today. Thank you, everyone. So, NSI will continue collaborations with all other association societies in course of time. Thank you, everyone.
Thank you very much.
Thank you very much.
Thank you.
Thank
Thank
you.
you
Thank
very
you.
much.
Thank you.
Thank you.
Thank you, Dr. Nair. Thank you. Bye-bye.
Thank you.